Hi, good morning, everyone. This is Renee. We're going to start in about 5 minutes. We have a couple of people still joining on. I'm going to give them a couple minutes and then we'll begin. Thanks for being here. I'll check back in a couple minutes. Welcome to our webinar on digital solutions. My name is Renee Gordon, and I am the Marketing and Sales Manager at HTSI. I hope you can all hear me. Thanks for joining us today. Some of you here with us are already familiar with us, but there are some folks that are meeting us here for the first time. So I'd like to extend a special welcome to you all. To get better acquainted, I'm going to do a brief introduction about HTSI. Okay, so HTSI, we are a diagnostic imaging sales and service provider. We've been in operation for over 10 years. We have offices in Florida, Trinidad, and Barbados, where we developed our operation. And since then, we expanded our territory to other Caribbean countries, such as Jamaica, Guyana, St. Lucia, St. Vincent, among others. At HTSI, we really pride ourselves on customer satisfaction and delivering on our commitment to service excellence. So we partner with OEMs and vendors that share the same core values. And for that reason, we are proud to represent titans in the industry like Hitachi for CT, MRI, and ultrasound equipment, and also Paxerahealth for innovative digital solutions. Today, we are very excited to partner up with the team at Paxerahealth to discuss key topics that are shaping how we operate in today's very unique environment. As you know, the pandemic has forced facilities to rethink their patient care and workforce safety. Remote interpretation of imaging studies, it contributes to social distancing and it protects radiologists in the hospital while allowing interpretation of capabilities in emergency scenarios. Similarly, migrating to digital image sharing platform will also contribute to social distancing by reducing patient visits to collect studies and the actual physical transfer and additional costs associated with consumer media like film, CD, DVD, and USB that we're using today. Today's technology allows doctors to access images through a PAC system from anywhere in the world, working internet connection and web browser. Whether it's a physical server at your site or through cloud storage, there's also powerful imaging sharing applications that allow images to be shared via apps for your smartphones or a secure URL, a web link. And Paxerahealth with us today, they are one of the best 3 companies in KLAS. KLAS is an independent and unbiased organization that provides insights on the healthcare IT industry based on actual customer feedback. Paxerahealth has been awarded Best in Class for Global Software in 2020. With that, I'm proud to hand you guys over to Mark Collins here with us today. He's the Senior Product Specialist at Paxerahealth. Mark has 37 years clinical experience in CT, MRI, orthopedics, and mammo, and 15 years industry experience specifically in DICOM and PACS, and he comes with a wealth of knowledge to this field. So Mark is going to spend the next 35 minutes for a presentation. During this time, we're going to keep the audience on mute. At the end of the session, we're going to have 10 minutes for any question and answers that you guys may have. Please feel free during the time to post your questions in the chat box of the webinar, and we'll address them at the end of the Q&A on the bottom right panel. Thank you. Mark, I'm going to give you the floor.
Okay, thank you, Renee. We appreciate the opportunity to come and present. As Renee mentioned, teleradiology has become so important in the past few years, but especially the last 6 months. And the teleradiology platform really, as Renee mentioned, brings an opportunity for a mobile viewer, image sharing, any coordinated solutions for the providers to help focus on the imaging and their patient care outside the facility, and minimizing this person-to-person contact that we all know can create environments that create, a worse possible COVID exposure or any contact of flu or anything. So it really just minimizes that person-to-person contact. So I'm going to talk about a few products that we have, and I want to start with the RIS product. So our radiology information system allows us to really just create a really intuitive workflow, and the platform allows for just radiology data management from the point of being scheduled and simple workflow for the whole radiology department, all the way through the end of completing that, whether it's scanning documents or bringing in any data that is needed for that patient into our RIS information, the radiology scheduling program. It's web-based. It can cross a platform. It can be controlled on any browser and can be done either in a local hardware on site or a cloud solution or any hybrid thereof. And the cloud solution really is an opportunity for a lot of outside physicians or employees to look at images and radiology reports without invading the main server at each facility. Fully automated workflow, minimizes paperwork, does some predefined work reports through dashboards and monitoring of each machine, each CT, ultrasound, and what they are doing daily. Just complete workflow tracking all the way from scheduled through the imaging process. We can control some turnaround times for reports. It integrates with any EMR, either through API or HL7. So we can pick up scheduled patients if they already have a program and drop it into our radiology information system through one of those means of communication between the platforms. So it has some advanced workflow in it for insurance and collection of monies. And again, just some dashboards for your planning day. So upon logging into the radiology information system or the RIS, you can see that I've scheduled a couple patients. And within this being scheduled, if there's a need for us to scan documents and put those into the system, you can scan any patient documents like an order or a script. If it's important that we do gather insurance information, whether it be government controlled or private, or someone on holiday on your island that they want to abide by what's happening maybe in the country they live in and provide those insurance documents for recording purposes, easily attached through a scanner in this situation. So I can open the patient's chart and you can see I had one that was scheduled, but within the chart, I'm able to put in reason for exam, maybe the clinical information on the patient, that they have MS and they need some assistance, an extra employee. They have the shakes and prior to the CT might need some medication. All this can cross over from the RIS into the PACS system itself. So the chart allows for some more detailed work and allows for us to collect some monies. So for me, coming to the island from the United States, I know that I would need to pay a portion of what the fee is, and I can collect that money and produce a receipt for that particular patient so that they could have it for tax purposes, insurance purposes, maybe just personal reasons to keep that. So really nice information to collect dollars and collect insurance information if I need to do that. And again, inside the RIS, I can take it from scheduled. I can make one click and tell it that the patient is in progress. This just shares with everyone now they're in the imaging suite. So whether they're getting an ultrasound or a CT or an X-ray, just allows everybody across the system to know. And there's a chat program that you can use. There's an opportunity to share this, even web-based, multiple locations. So if I had 3 or 4 clinics and a main hospital, all those can be added in here and can be separated out individually if needed. There's a dashboard out of the wrist that we can run, and it just shows every single machine and how many exams are scheduled in that machine for that given day. So the radiology system, again, just brings a comprehensive, detailed environment for us to be able to see a list of everybody that's scheduled, whether they're in progress. And this is my work list versus my actual schedule book. So it gives the facility a chance for people to get comfortable in one environment or the other. And so the risk really leads to scheduling, collecting data on the patient, and then driving it into our PACS environment. So in progress means that this patient was getting imaging done, and then we want to change that, which we can do to completed. And I will save that and go back to the work list, and you can see now that the color has changed, and these are all customizable by each facility. So now that I'm completed, I actually leave the risk system. I don't leave, I just stay there as a completed study. And now the imaging is going into our PACS system. And the PACS system had a similar login screen. So what we name all of our PACS system, it's Ultima 360. And you can see that my work list is here and very detailed. So from this screen, I'm able to select that I want to do just studies from today and a certain modality of CT only. And if I would do a search for that, it would bring up all that criteria, but easily allows me to come in and name that CT, nuke med, ultrasound, any name that I want, so that as a radiologist or a provider, I have a very detailed work list of my patients and my patients only, whether I want to see unread studies or what we call verified, which is a complete radiology report, and it sets within the PACS. And so it allows for very customizable, and as you can see on my list, very detailed for a lot of the demos and presentations and training that I do for all the customers that Paxerahealth has. Back to the work list, this is my customized work list based on a keyword that I put in, and whether I put in fracture or orthopedic, or I name it Mark for my name, just an easy filter for me to get back and forth to what I want to make most convenient for myself. So a very customizable work list by columns. This is all can be controlled by the user, or someone at the facility can work with me to build a super user account, if you will, and we can push this out to other people so it doesn't have to be customized for every single employee. Left click off of my PACS work list allows me to come in and bring in images. And if the radiologist or physicians, orthopedic surgeons, whoever it might be, if they have multiple monitors, this can be laid out on multiple monitors. And for the radiologist, we can also automatically bring up the radiology report program so that they can begin to dictate. And we can dictate by typing. We can dictate by voice recognition. So if is preferably uses Dragon or M-Modal or PowerScribe, we integrate to those, or we can have them do Dragon and we do the Dragon training ourselves, and it's just voice command to complete the radiology report. Along with the images that just brought up, we display a timeline, very unique in this PACS system, that we do year to month to date timelines. And those priors are all brought together based on patient ID and first and last name match. The uniqueness of this is a year to date to month timeline, but we also wrote code. So if the providers were commonly a list of priors, we also write the code so you can see the list on the left side or use the month to date timeline layout. So if there's an MRI that applies to this particular ankle study, then I can bring that MRI in and I can see what maybe coordinated or originated why I would do the MRI scan itself. And the comment box that you see popping up is a comment that can be done by anybody that does the initial read, maybe an ER doctor from the emergency department, or maybe a junior radiologist that's doing the initial read. And then the senior radiologist wants to see their notes. So these auto pop up based on one indicator off of our work list where we type this information in. So easy to see any prior studies and compare them side by side, and allows for duplicate viewing. So if I had 2 chest x-rays, I can put them side by side and view those at any given time. Now from within our PACS work list, and of course you can see that we can pull in multiple studies, including dental, including any ologies, so that we can capture pathology slides and we can import those even though they're not DICOM, and we can do extensive cardiology work. So within the cardiology program, I've decided that I want to see the ultrasound of the echo that led to the concerns. And at the bottom, you can see that in my software that I can run a SNA loop on that if I want to, if that's the desire of the cardiologist or the radiologist looking at the exam. So the echo may be led to saying there's a concern in these images. I think the patient should have an EKG. And these EKGs oftentimes don't send DICOM, some do. We can capture that easily. But we can also scan this, or we could import this from a file off of the PC and import it and make it look DICOM, which we have done here. And post EKG, then the physician says, I really think they ought to go to the cath lab. And I think we ought to have an exam. So if there's not a cath lab at your facility and the patient brought a CD in, then we can import that CD, and I'm just rolling the wheel to simulate the flow of the dye through the heart. And so you can see a real layout of the echo, then the ECG, and then the final exam to determine what's our next step of care for the patient. And that's to do the cath and then decide how we're going to care for them. And again, a lot of detailed information on prior exams, or the list on the left-hand side makes it very easy for us to decide to not display one of those priors. So just a friendly environment for all modalities, and orthopedic specific if needed, CT, MRI. From this list, I want to talk about a share program, and we have some share opportunities. This comes from our right-click menu, and if I go to share and add share, from my add share program, then I can come in and share that this patient's information is very important. I want to send it to a specific user, right? So Dr. Collins ordered it, but I want Dr. Brannon to see it. He's a friend of mine. He works within the system, but he didn't order the study. I simply can push that to Dr. Brannon, and I can determine, and this can be done by administrators, technologists, all controlled by permissions. So if you don't want someone to be able to delete a study, that's all controlled in the environment per user. So if we want Dr. Brannon to just see this study for 24 hours or 2 days, we can set a timeline on that and then share it. When Dr. Brannon logs into the system, it would be sitting right here in Dr. Brannon's work list. And therefore you can share it even though that provider did not order it. That's share number 1. Share number 2 is in the tools off of my left side menu, and allows me to open up the send to another PACS program. And if I want to add that, and I can obtain from an IT group the AE title, the IP address, and the port. Once I build that, what we would call a DICOM node or a DICOM host, and it would always sit here. And if I clicked it, within 2 seconds, it would send that patient to another PACS and allow a provider like a radiologist that says, I have a cardiac specialist in radiology. He doesn't have Paxerahealth PACS, but I can share with him, and it would share that in a shared environment. So facility to facility, provider to provider, and then in a quick CareRad share allows me to actually send this to the patient's phone. So our CareRad is facility to patient's phone. You put the phone number and the email address in, and the patient gets a link, and they're able to open that link and be able to see their images as well as their radiology report. And I want to talk about a fourth share opportunity, and the screen will pop up. On a right click, I can go to share with patient, which is the bottom portion of our share. I'm telling it to share it to the IP address or the website to this particular email of this particular patient. Now, I want to indicate to you that we do this to providers as well. So if a provider would want this patient information and the patient's okay with it, then I can send this. And what it does, it sends a link inside that email address to that particular person. It doesn't make any difference it's the patient or another doctor. I click on what we call the tiny URL, and it opens up what we call a zero footprint viewer. I will type in the patient's name, so I would need to know the name and the date of birth. Upon entering that data, it's going to open up images in this zero footprint viewer. The zero footprint viewer means that I don't care if you send it from Trinidad back to Florida or back to where I live in the middle of the United States in Missouri, as long as it's an email address, which is worldwide, right? I don't need any plugin. I don't need any executable. I need absolutely nothing. It will absolutely open up every image and give full detail of those images. Now, if it goes to a provider, I can click on the measure tools. I could do a measurement myself. I could do an ellipse and circle an area of a concern. I can make a line across an area that I think is important for me as a provider, and then maybe talk to the radiologist to see if they agree. But the zero footprint viewer does not affect any of the images on the hard server. It leaves them completely alone so that the radiologist doesn't see any markings if they don't want to. I can drag in any sequence that I want. So again, the simple explanation of a zero footprint viewer is it leaves no mark on the PC and requires no activity by the patient or the provider or anybody that we share with, any function at all to make this work. So it just is truly total zero footprint. And this is live, by the way. So you can see this is a pretty big file. These are very extensive MRI studies with sequences of anywhere from 1 to 35 exams or images inside one sequence. So they load very quickly as well. So that is share with the patient, which really leads to a true patient portal. And I know that we've all heard the patient portal, physician portal over the last 5 to 10 years. And at times, those portals can be convoluted, and it takes a bit to try to get the username and password to the patient. So this is our patient portal. By sharing that right there allows you to open a portal just specifically for that patient to see their own images and their own radiology report, which we know over the last 10 years, it's been really important that patients say, I don't want to come back to the office. I'm a 35-minute drive, and I don't want to make that drive and pick up a CD and a piece of paper with my report. So an easy way to share digital images, and we hold the radiology report inside those digital images as well. And as you can see, I can communicate with the patient, and the patient can bring up any of those exams that I send to them in any radiology report. and it can be held on the device that they're looking at those on. So really just 4 really good share opportunities to minimize the cost of CDs, flash drives, anything that we would burn. So that is our share opportunity. And you can see the images are coming up now on the phone application. It can be done on a tablet, it can be done on the phone, it can be done on a PC at someone's house, and it could be done even on an iPad. Okay. I want to talk about one more step that we have, and this is artificial intelligence. Now, artificial intelligence is being done by a lot of different companies. It's all very easily performed the same way. I shouldn't say easily, but basically we take the shades of gray, right? So when we look at images in radiology, we're looking at 256 shades of gray. We took a group of scientists, a group of radiologists, and we sent a lot of studies to them, whether they were normal or so-called normal, or they had pathology. And we analyzed those. And through different changes of shades of gray, we asked them to mark that that was pathology. And inside of that, then we can apply a heat map or a region to show concerns of that given area. So we did a lot of data sets to get the algorithms done. Artificial intelligence is nothing more than a mathematical equation and an algorithm to determine, are there changes in these shades of gray in this person's anatomy? And if so, what type of pathology does that lead to? In our data sets, I'll start with our CT neuro. And once the facility decides we want all the CT heads to go into artificial intelligence, if it's normal, my side menu does not come up. It just leaves it blank so that the radiologist can scroll through the images. If there's pathology, the chatbot or the AeroBot program that we have says, I've analyzed it. I took your information from your scientist and your radiologist and said, when there's a change of anatomy in the brain that leads to ICH, the intracranial hemorrhage, I'm going to tell you 95% of my mind in this AeroBot program thinks that this may be subarachnoid. There's a 24% chance that there's a subdural that goes along with it or that it pertains to. The heat map just colors it, just gives a given area of that region. I can turn the heat map off and just say, just circle it like a radiologist would have years and years ago, whether it with grease pencil and film or digitally. I'm marking this now with an annotation marker, or I prefer to go back to the heat map. And as the provider, I can indicate whether it makes sense. I can have a resource hub that tells me that I can go and look up indicators from a radiology assistant program, or I can agree with it and I can actually do my report from here and complete the radiology report. So CT neuro is our first anatomy that we have. And as you can see, I'm back to a work list, filters, and I'd like to look at my chest x-rays. And I'm going to double left click and open this study. And within the study, it comes up and it says, all right, Mr. AeroBot, asking really truly our software that the scientist and the radiologist perfected, what's in that given area of that region? Is that a pleural effusion? Do I just have some atelectasis going on there? Or is it possibly even leading to tuberculosis? Obviously, the radiologist knows the next step, and so does the referring physician. Order a CT or whatever the case might be. But for me to look at this and be able to agree and go ahead and do a radiology report, and I can do calculations from inside my AI software, just like I do in my PACS. I can measure, I can change brightness and contrast. I'll measure the cardiac silhouette just to see the size. I'll change the brightness. I want to see if I can really see something in the lower area of concern from the AI. And if I'm done with that, then I can just close the study. So our second anatomical area is chest x-rays. The third anatomical area that we have for artificial intelligence is mammography. And I'm opening the mammogram, and I can get the images to come up. And my chat program says to me, "Doctor, I feel like on the right side, I don't see any extreme densities. I don't see a malignancy. I don't see any lesions at all on those right breast." And I'm going to give it a BI-RAD category, which is very in the United States that we BI-RAD everything out. 1 and 2 being so-called negative, all the way to 6 of you have cancer and we're very concerned about you. On the left side, you can see it's talking about a 99% possibility of malignancy. And as you can see in this program, I have a lot more information about the patient. And this comes from the EMR. So we integrate with any EMR, again, like I mentioned before, through API or HL7. The more data that's put into the EMR, the more information the referring physician and the radiologist or the surgeon gets from that. So this is all a EMR or HIS integration. And again, I can view it as a region. I can ask it to just apply a heat map for me, show me heat-wise your areas of concern, or just go back and make a circle or ellipse or a drawing around it. So those are our 3 anatomical areas, and every week we work on moving to another anatomical area and getting a data set. And the data sets that we really performed were somewhat large. We did over 140,000 chest x-rays. We did 13,000 plus mammo images, 36,000 plus CT slices. And a lot of the data sets were much, much larger than that because there were normals. And we don't count our data sets when we see a normal. We only count it when we do pathologies. So that is ongoing every week with Paxerahealth and the continuance of moving to each anatomical area in the body to perfect our artificial intelligence. So back to the PACS for just 1 minute. I just wanted to share that, again, I showed the images. I can do a radiology report very quickly and auto-open that radiology report or transcription module. Really, really fast streaming, as you saw, and it works on any bandwidth. We can share the images, as I showed you. We can also retrieve. So we can go and ask for studies from any other PACS or move images to the cloud environment. So the PACS system is freed up where maybe 6 months or 1 year sets in the cloud for easy viewing for the referring physicians or anyone else that would use the cloud. And of course, it allows for the sharing of those images and reports and records to the patient, as we showed. But really just maximizing the whole productivity for the radiologist and referring physicians with all the tools that you need in any viewer. Some business analytics, as I showed quickly in the RIS. We also do some analytics and metric type of stuff in the PACS. So we can see NucMed is how busy today. The ultrasound machine has got 13 patients or 1. And from here are some very, very detailed reports that we can run based on how many did Dr. Smith order in the month of July? How many CT heads did we do in the month of August? And that can be saved, driven into an Excel, pushed out on an email to executive, board of directors, whatever the case might be. So the dashboard and the analytic reports are automatic based on how we build the back end of the PACS system. And I think at this point, Renee, I think I've covered the risks and the PACS and the viewer itself and the tools that are available, and us knowing that it can be hardware on site combined with cloud if needed, and a little bit about our artificial intelligence program and how it works. And I think at this point, with those 3 products combined with our share opportunity, which by the way, from our AI is we can share also. So we don't hinder the share based on any of the studies that we do. We allow share throughout our whole platform. And I think at this point, Renee, unless you want me to show something else, I think we want to leave this open for some questions and answers about you as our partner and about the functionality of Paxerahealth.
Well, first, I want to thank you so much, Mark, for your detailed explanation and showing us the varied options in technology by Paxerahealth. At this time, I believe I've seen someone raise your hand. Gaia, I believe you say Allison has a question. Can you unmute Allison?
Is she speaking? Renee?
Sorry about that. Yeah, I'm sorry. I had a little technical problem where I was muted. Okay, sorry, guys. Allison, I think you have to unmute yourself if you need to ask the question. If not, you can type it at the bottom. In the meantime, Mark, I did have a question written down that I received from someone prior to the conference, and the question was, on deciding whether, going with a cloud PACS versus local on-site storage, which do you tend to see more of, and are there any pros and cons associated with that decision?
We see both, and the hybrid has become very popular. So we have a lot of facilities that want to control the server. They may even already own hardware and don't want to make an investment of a big server like that. So we sell software only, which is an option. But the on-site server really allows for, the viewers are very powerful, whether you're in the cloud or in the local. So what we're seeing is a lot of sites buy the local. And I'll give an example of a site that's going live next week in the States. They wanted control of their server, and their IT group is very skilled. They rely on us for backup support and the dealer, just like you. So they take the first call, but we assist them. The cloud then is reserved for the referring physicians, because the referring physicians are going to look at it at home, at an office that maybe somebody else owns that office, an entity group, and they control the computers, and they don't want to leave a footprint. So the cloud just creates an opportunity for them to view images without any invasion of the main server on site. So what we're seeing more common now is really a combined environment of both. The cloud version that I'm teaching later today has been bought by a community college. So in the United States, the community college, as of last year, in the radiology programs where they're making new x-ray techs and they're building new ultrasound techs, which we all need, they buy a cloud environment because they don't need the ability to always have the robustness of the hardware, the server that brings on site. So the cloud environments sometimes belong and get owned by smaller facilities with fewer users, or you've got 20 radiologists that maybe are reading, like my site that's going live next week. The radiologists want to use the on-site server, and they're in the building every day. So they don't particularly want to go to the cloud or need the cloud, because they want everything saved, and the IT group is comfortable downloading an executable to make the transcription module run, to make the viewer run, to make CD burn work, to make import work. Where a small facility or a community college wouldn't need that, and so they're cloud-based only. We're really seeing a mix a lot, Renee, of what to do, but the ideal scenario that we see is hardware on-site with cloud access to anybody that's looking at it remote and using the zero footprint. I hope that helped.
That did help. Thank you so much, Mark, for addressing that answer for me. I am not seeing any questions here in the chat box. I do not have any follow-up questions. I know someone raised their hand, but if you do have a question, please unmute yourself, and we can address any questions you may have while we have Mark on the line.
I'm trying to help Allison, but I can't get her unmuted, but I see she's raised her hand. Sometimes in this arena, you can use Shift 8, which is the star or asterisk. Shift 8 and the number 6 sometimes will unmute you if you can't self-unmute. We'll give Allison a second to see if maybe we can hear her. And I actually see her in twice, so I don't know if she's trying to speak through the computer or if maybe she dialed in via phone.
That's okay. Well, Allison can also type if she had a question she'd like us to address. And if there's no one else that may have any questions, I would like to take the opportunity to say that if there is any more information required from us, I'm happy to help on anything, whether it be the AI or the PACS. Definitely, we can have any conversations offline further. So with that, Mark and Dyer and all of our audience, thank you so much for taking the time today and joining us. Look forward to speaking with you all soon.
Okay, I would like to also thank everyone for attending. Everyone's busy and it's hard to get free. We feel very honored to have HTSI as part of a combined program with us. And Renee, we really appreciate you taking the time. You've spent a couple of weeks just organizing and setting this up, and we're so happy to be a part of you. And we want to thank you so much for allowing us to present. And Dia and I just hope that everybody in this situation, and as the future goes forward, can stay safe and well and stay protected, and that your families are in the same situation.
Okay. Thank you so much, Mark. All right, everyone. Have a good day.
Thank you.